Hi, Dr. Aldarondo.
Hi, Christy. How are you?
I'm good, thank you. Hey, thanks for spending time with me today between patients, and thank you for being one of our country's frontline heroes, working tirelessly during this time, which is unlike anything we've seen or experienced before with this COVID-19 virus. We've received a lot of questions from clinicians all over that are treating patients that have been diagnosed with coronavirus. But before we get started on that discussion, I wanted to ask you just to tell us a little bit about your role with PN Medical.
Well, thank you, Christy. Thanks for those words. Yes, I've been involved with PM Medical for probably 6 years now, 7 years. And prior to that, unofficially for a long time, because I've been familiar with the respiratory muscle trainer device that PM Medical manufactures. And as a pulmonologist and in my hospital and involved with a pulmonary rehab population, I was familiar with the product for a long time and had a lot of interest in that the concept of rehab and the additional benefits of respiratory muscle training in that context. And a few years ago, Mark asked me to come on board and help him with the development of the device and introducing the device into several clinicians and areas of interest in not only pulmonary but cardiology and medicine in general. Respiratory muscle weakness is incredibly ubiquitous, prevalent, and it's just been a wonderful activity to be part of because of the nature of it and the frequency which we encounter it. Many times not even aware that it's there, but it's there. As you know, I'm a pulmonologist, and a lot of what I do directly or indirectly has to do with this issue. So it's been a wonderful journey, and very rewarding to be part of this team of professionals that compose PM Medical.
Thank you. Now let's jump right in. Let's look at some of the questions that have come in over the past couple weeks. One of the first questions is, what's happening physiologically to my patient that had the diagnosis or has the diagnosis of COVID?
Well, it's actually a complicated answer. There's many things that are happening, and not everybody goes down the same path. But if you were to take from the very mild asymptomatic course of illness to the dramatic, escalating, life-threatening, and sometimes lethal clinical course, you have obviously a very wide spectrum. And I would like to say, for the most part, COVID, acute COVID illness, is not that much different than from others, coronaviruses like SARS or even influenza A and so forth. They all share a lot of common pathophysiology. Part of that is the direct impact of the viral infection on the mucosal surfaces, the respiratory tract, ranging from a mild bronchitis to a severe tracheobronchitis to a severe alveolar damage, resulting in hypoxemia, respiratory failure. But one thing we know for sure is that the patients that do experience a more severe illness, develop a life-threatening respiratory failure, a lot of that is not actually the viral infection. What happens at that moment is that there is a systemic response. They call it a cytokine storm. There is as the body basically responds to the viral infection, the immune response results in the trigger of proteins that basically recruit other proteins that result in severe inflammation, leakage of endothelial damage, and severe alveolar capillary damage, and so forth. But along with that, there's a cascade of events that have to do with thrombosis. There is an increased amount of a propensity for thrombus formation, and that thrombotic consequence of this cascade is one that appears to happen quite a bit more often with COVID, for example. So one thing we've seen with COVID that is a bit different from the others is that the vascular injury appears to be more severe, it appears more rapidly, and explains the propensity for thrombus formation, but also the severe hypoxemia that we see in these patients that escalate so quickly. That is not necessarily managed by intubation, as you may have heard by now. There is a realization that there's a good number of these patients that are ill-served if they get intubated and placed on mechanical ventilation, because positive pressure delivers an additional blow, if you will, to the integrity of the alveolar surfaces, alveolar capillary surfaces. So in terms of the pathophysiology and management of COVID, this vascular component, if you will, it is a bit different, and it's something to be aware of and watch, because to pull back a bit and refrain from going the usual route of intubation, mechanical ventilation, may actually be in the patient's best interest. There is, but because of the vascular injury, there's a higher incidence of renal failure, dialysis, dependency, for example, cardiac complications, acute myocardial infarction, and so forth. A lot of these are basically vascular events. So a lot of that is part of the systemic inflammatory response that we see with COVID, but also see with many other viral infectious illnesses. The common pathway being this cytokine storm, if you will. In the case of COVID, appears to be more common, more severe, and appears to happen more rapidly early on.
So what I think I heard you say is that with these patients, they're not so unlike other influenza patients in that they could have a mild case or it could become very complex. But there are certain other conditions that we see with COVID patients that we may not typically see with others. Does that sound like an accurate summation?
That is correct. And the other thing to keep in mind, Christy, is that we don't have immunity for this virus. We're completely at risk of the impact of the viral infection and the immediate response to the acute infection. We're not talking about the prolonged immunity that is resulting from a vaccination or prior exposure, in which you basically avoid the pathway of acute injury and so forth, because you already have a pre-existing immunity. So we have dealing with a very unique situation, that this is a highly infectious, virulent, pardon the pun, the virulent virus, or a aggressive particle, and that for which we don't have a pre-existing immunity. What we just said is basically correct. You stated that very well.
So I know a lot of the clinicians that have reached out to us are just beginning to see patients post-acute COVID. They've got a lot of questions. One of the biggest questions is, when can I start respiratory muscle training with my patient? So when can I start? And when I do start, do I have to be gentle?
In that regards, I don't think there's much difference that we have from anybody who's recovering from an acute respiratory injury that resulted in respiratory failure and may have required mechanical ventilation and so forth. The aftermath is not much different. There are issues there about the infection, about protection from the contagiousness of the viruses and secondary infection of clinicians and other healthcare workers and so forth. But aside from that, once the patient is, the sooner the better. The sooner we resume or initiate respiratory muscle training in anybody in that category, the better. So once the patient is, even before extubation, we do it on these patients on mechanical ventilation. But typically it's the patient who's now extubated, who now experiences a degree of acquired respiratory muscle weakness. That patient, there's no need to wait any further or any additional period of time. assuming another thing, there's several caveats, of course. Um, in the acute phase, no, there's no purpose or reason. In fact, you could say that it's contraindicated to initiate respiratory muscle training in the acute phase, because this is patients who have going through increased worker breathing as it is. They are hypoxic, and they're probably quite hypoxic, and you do not want to increase oxygen consumption when there is in a unstable situation where the oxygenation failure is a real issue. Afterwards, after they have stabilized, if their oxygenation requirements are now less, and the patient is worker breathing is decreased, and they do not require extraordinary FiO2 or oxygen supplementation, they may begin respiratory muscle training. There's no reason for not doing so. And it will be the same concept, the same rationale that we would follow for anybody who is recovering from an acute insult, resulting in first initially severe hypoxemia, prolonged increased worker breathing, respiratory muscle fatigue, all this cytokine storm that I was talking about. All that results in basically respiratory muscle, a separate muscle injury that results in an acquired myopathy. So, and that applies to any of these patients. In the case of COVID, though, and as I said, we do have an additional concern regarding how this is done, because now you have somebody who is going to be potentially generating aerosols with the virus in it.
Yes.
So anytime you do, at the time, probably the most critical exposure that a healthcare worker can get is in the process of intubating a patient who has a COVID infection. This is the most significant aerosol generating experience or circumstance. But suctioning and so forth. But by the same token, when they do a forced inhalation exhalation maneuver, any healthcare worker at their bedside should be avoided. Either they have to be present, they should have their personal protective equipment with them, like they would do normally. And in as much as possible, the patient is auto-sufficient and they're now able to follow instructions and reasonably stable, I would recommend that there's nobody in the room as the patient is doing that. They can be monitored, across a glass surface through the window and be guided, or even remotely. They can get the initial instructions, but as they do that, there's no purpose in being there or right there at the bedside with the patient. I would discourage that.
So that's in the initial infection period, is that correct?
That is correct.
And when you suspect there may still be active COVID infection, am I understanding that correctly?
And that would be for a number of weeks afterwards, not during the first few days. We're looking at least 21 days, and quite frankly, we're not even sure exactly what the perfect window to. We're talking the longer the better, but we're talking at least 21 days or further.
21 days from known infection, is that correct?
Correct.
Okay. So that brings us to a lot of other questions that we got. One that you talked about a bit already, that aerosoling effect. So when we use the breather and the patients exhale, they're creating a bit of a larger area of respiratory signature than typical just talking to each other. Is that correct?
That's correct.
And so that's why I think that you were recommending having the patient use this really by themselves after initial instruction.
Yes, that would be the most sensible thing to do.
So at PN Medical, for those who don't know, we do have videos on our website, and we're happy to share them with anybody who needs them, so that clinicians can show patients the video that demonstrates how to use the breather, but also there may be indications for telehealth. More and more clinicians have accessibility to telehealth. And one of the things that we did at PN Medical was to create a video, how to teach a patient to use the breather via telehealth, because most of us, including myself who's an occupational therapist, we're used to being one-on-one with the patient, being right there with the patient. But in those times, until we can be back with our patients, we wanted to be able to provide clinicians with a demonstration on how you might explain that, how you would provide that teaching and training via telehealth. So we wanted to mention that that is available on our website, as well as the videos.
Absolutely. And you can be creative about that. For example, you can be interacting with the patient, you can demonstrate in front of the patient, you can follow up on your observations, and facing the patient with your proper protective gear, you can demonstrate to the patient how it's done, or correct it. I noticed that you did this or did that. If you're talking about coaching initially, there's somebody who is in need of proper training. But at the moment when they're actually performing, then you don't need to be there immediately, facing the patient. You can actually remove yourself and do it remotely. So there are ways to do that that still will serve the purpose, and I think the patient will be well served that way.
And another thing I wanted to point out is sometimes our patients don't get it 100% correct. We teach them how to do it correctly, but they may not use it exactly the way we ask them to or demonstrated. In your experience, is that going to hurt anything if the patient ends up using it by themselves without a clinician, and maybe they're not doing the breath as long as we would want them to do it? Or
the first step is very important. The first step will never be perfect, but I think the first step will be one of familiarization for the patient, to eliminate or dispel any fears or misconceptions on the patient's part. It's a discovery process that they will understand. They will internalize a lot of what you're telling them. And once that clicks, they will latch onto that and they will do better and better and better. So it's a learning process. So there's nothing to be wasted on the first attempt, and it will never be perfect.
And I know you use this in your practice and you teach your patients. Yeah. So I think also in the case where there may be a caregiver that has to provide teaching and training, maybe we're not so worried about it being perfect initially, but like to your point, making them familiar with it, understanding why this is important. Why should I be using the breather right now? What is it going to do? Conveying that to the patient, what they can expect, how it's going to help them. Do you find that helps with compliance? Completely.
And like that, there are many other examples in medicine in which the patient had told, here, take this, use it.
Yep.
Or for example, write a prescription for blood pressure medication and walk away. And expect the patient to, just because you wrote a prescription, expect them to follow up on it without telling them, look, this is why we're doing this. This is what happens if your pressure is high. This is what will happen to you 5 years from now, 10 years from now. This is what your life will be like. This is the rationale for this. And that's how you get engagement and you get compliance. If you get somebody to breathe there and just tell them, listen, do this and this and that, but you don't tell them why, and you don't explain to them the importance of increasing the physical endurance of these respiratory muscles, and how that translates into the improvement in their cough and improvement in their potentially dysphagia in the patients that do have that issue as well, et cetera, et cetera. So you provide that context, you provide the rationale for it, and at the same time, you explain the mechanics of it, and then you supplement that with the visuals that PN Medical provides as well. But it's a very important moment. That moment early on, that teaching moment, is one we should always capitalize on.
And then we have opportunities, especially as therapists or nurses, we have more opportunities to re-engage with the patient, to perfect that technique if necessary.
completely. Yeah, this is not just a one-time deal. This requires a recurrent reteaching, emphasizing, correction, dispelled misunderstandings, and so forth. But at the same time, it's like many other things we do. It's a learning process. You don't get it perfect the first time.
And one of the things you mentioned, you talked about one of the benefits of respiratory muscle training being related to dysphagia. I think it's really important to touch on who should be doing respiratory muscle training.
Mm-hmm.
You know, I have my feelings about that, but I'd like for you to talk a little bit about who should do it. Whose job is it to do respiratory muscle training?
Well, I think you're talking about a lot of people. The prevalence of respiratory muscle weakness is very high. So universally, I think anybody who is in the perioperative cardiovascular arena, whether they're having open heart surgery or open heart surgery of diverse types, those patients have been shown to have a better perioperative course if they optimize their strength and resilience and performance of the diaphragmatic and diaphragms and accessory respiratory muscles. The patients who have congestive heart failure, almost universally, particularly moderate to moderate severe and further, these patients have a high prevalence of respiratory muscle weakness. Not to mention the secondary benefits, cardiovascular benefits of respiratory muscle training through the so-called metabolic reflex. Uh, there's a very large number of people who have neuromuscular disorders, who have chest wall deformities, who have a mechanical disadvantage for their respiratory muscle function, like severe kyphoscoliotic patients. And the patients who have chronic lung disease, as a group in general, particularly the bread and butter is COPD, who have a hyperinflated chest, who are struggling because their diaphragm is at a disadvantage because of the hyperinflated chest and so forth. For other reasons, so these patients do experience respiratory muscle weakness, and they are part of their long-term benefit is of therapy includes that as well in the context of rehabilitation. But we have a lot of patients that are, because of other illnesses that are not primarily pulmonary, are forced to be less mobile and become more sedentary and become weak and develop severe progressive debility. When you actually measure the respiratory strength in these patients, it's actually low. And you do that by measuring their MIP, MEP, or maximum inspiratory pressure, maximum expiratory pressures. And these patients have almost a selective, in terms of respiratory function. The only thing you can identify in these patients is they have a weakened diaphragm or weakened respiratory muscles. So these people actually may benefit as well from, aside from other things that they can do to improve their, like for example, the nutritional status, a well supervised mobility program, and optimizing cardiac function, stroke prevention, et cetera, et cetera. These people actually would benefit from respiratory muscle training as well. So you can see it's um, a very wide spectrum of clinical scenarios in which the common denominator is respiratory muscle weakness. The thing is that you need to be open-minded and you need to be mindful that these exist. And when you have any doubt about it, you can test it. You can do a pulmonary function testing on this patient with specifically measuring MIP, MEP, and single that out. Other times, that's not necessary because we know that in the hospital, in the ICU setting, and the post-ICU patient scenarios of acquired weakness and so forth, this is so prevalent that you don't have to do so. You don't have to measure. In fact, it's not the right moment necessarily to do MIP, MEPs. But You asked me who should be tested, who should be benefiting from respiratory muscle training. A lot of people, and I did not even touch on the dysphagia that you mentioned a while ago. There are several neurologic disorders, like, for example, Parkinson's, in which dysphagia is incredibly common, and stroke patients and so forth. And we know that by doing respiratory muscle training, there are a number of parameters that has been actually, there's a nice study coming out soon from Dr. Bob Arnold and associates that it will shows very nicely on how you improve several of the well accepted parameters that are utilized in the measurement or assessment of patient with dysphagia when they get respiratory muscle training. So there is a lot of common shared functions, if you will, of the respiratory muscles, and particularly when you include upper respiratory muscles and your lower respiratory muscles. By that I mean upper airway, lower airway, the diaphragmatic, the diaphragms, the intercostals, and so forth, that are more directed at bellows function, whereas the others are more towards upper airway patency. So it's fascinating. There's a lot of, and of course, there's a lot of comorbidities or coexistence of these. But I said a lot, but because obviously, and I basically scratched the surface. There's a lot to be said about the prevalence of this condition and the benefits of such a simple intervention, which is what we're talking about.
Yeah, and you mentioned a lot of potential individuals with respiratory muscle weakness. And so in my experience as an occupational therapist with well over 20 years of experience, I have seen these patients, and I know our colleagues have seen these patients in a multitude of settings. We see them in acute care setting. We see them in subacute rehab hospitals. We see them in skilled nursing. We see them in home health. We see them in outpatient. And I'm sure there's a lot of other places that I'm not thinking about. And so in those places, there are a multitude of healthcare clinicians. And among those clinicians, there's not one scope of practice that owns respiratory muscle weakness. I know we talk about this a lot, and we talk about who should be identifying respiratory muscle weakness. And in my opinion, and I think we share this opinion, it's anybody who comes in contact with those patients who have respiratory muscle weakness. And so I think the only limitation is our own understanding of that. And that's why we're doing exactly what we're doing. And that's why we have Breather University as part of what we offer at PN Medical, because it includes disciplines like doctors, nurses, respiratory therapists, physical therapists, occupational therapists, speech language pathologists. And I've heard so many different things from different clinicians saying, well, I didn't learn that in school. Well, I didn't learn it in school either, but I've learned it through continuing education, through my exposure to patients with different disorders. And so I think it's important that we as healthcare clinicians make sure that we seek the education to be able to identify and treat this, especially right now, especially while we have this pandemic going on that's resulting in probably more respiratory muscle weakness than we typically would have seen. And you talked about intubation. So I know that a lot of times respiratory therapists may be the first clinicians that identify and begin treating respiratory muscle weakness while patients are still on mechanical ventilation. Now, that may not be the case with most COVID patients, but if we're looking at respiratory muscle weakness, one thing I know that I've learned is within 6 days of mechanical ventilation, so less than a week, generally you can expect a 30% reduction in diaphragm strength. And diaphragm is pretty important when it relates to breathing. So I know respiratory therapists may be involved early on. Sometimes nurses are the only healthcare clinician that's involved in a case, for example, in home health. there may just be a nurse that's going to see the patient. So for them to be able to identify and treat respiratory muscle weakness is important. As an occupational therapist, I may be the one identifying and treating, or I may be in a supportive role where the speech language pathologist or the physical therapist has introduced respiratory muscle training, and I, as the OT, am going to work with that patient on incorporating it into their activities of daily living. You made the point earlier on about how important it is for individuals to continue to use it, for this not to be a one-time only, here, use this thing and be done with it, but that ongoing reinforcement of using the breather to continue to strengthen the muscles and then maintain that strength. Because just like any other exercise, you can't just strengthen it and walk away. You can't go to the gym for 4 weeks, think you look great, stop going, and expect those benefits to continue. The same is true with respiratory muscle weakness, is once you do strengthen those muscles, you need to commit to a lifelong routine. And so I say that because as an OT, we're all about routines and habits. And so if I can help an individual put this as part of their routine, after they brush their teeth, or while they're watching The Price is Right, or I don't know, some other show that they enjoy that they've recorded, to partner this with something in the routine will help with that consistency and help to maintain those benefits. But there's more and more studies coming out about respiratory muscle training. One that I thought was fascinating and should not be surprising, but respiratory muscle training as a way to decrease fall risk. And when we think about the muscles that are strengthened during respiratory muscle training, that makes total sense. That makes sense that the muscles of postural control are also some of these very same muscles of respiration. So there is a role for all of these healthcare clinicians. And you briefly mentioned dysphagia and phonation. So speech language pathologists being involved and along that spectrum of care. Imagine a world where we're all educated in recognizing and treating throughout a spectrum, throughout a continuum of care. Then our patients will get stronger and maintain that strength, because it's not going to be just one discipline teaching one time. We're going to be reinforcing that message.
Christy, I completely agree with everything you said. And I was listening to you, I was thinking of something. Like many other things, depending on what from our perspective, depending on what our biases or maybe our interests or goals, when we approach a patient, it is what we see, right? So if I see a patient I have a breather in my hand, or I'm thinking respiratory muscle training, and what I'm thinking is respiratory muscle function, shortness of breath or dyspnea, and I want to improve that patient's dyspnea by improving diaphragmatic strength, and that will lead me to what I want to measure. What I'm going to measure? Well, I'm going to measure their ability to travel a certain distance. I'm going to have them rate their own shortness of breath, perhaps using a Borg index. And I will do perhaps a 6-minute walk and blah, 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 right? So I look at parameters that will help me trace that progress, that I can actually quantify the improvement in that area. But I may not be looking at other things that were happening at the same time because I simply was not looking.
Sure.
And to me, there's several flip sides to this. And there's you mentioned core strength, you mentioned gait, balance, and so forth. Look, that is hugely important. That's a platform on which the respiratory function is based upon. And it's funny that when we talk about accessory muscles of respiration, those accessory muscles of respiration become the primary muscles that probably have to do with gait control and balance and so forth. But it's like two different ends of a muscle system, two different aspects of muscle system that have to do with a complicated interaction of functions or codependency that is mutually that is synergistic, and so as my point is that we should have a more holistic approach as to when we look at a patient who is having shortness of breath, because the patient with shortness of breath, by definition, a very severely short of breath patient is already a fall risk. That patient is the one that's going to be falling and breaking their hips, okay? Or the patient who is weak and the patient who has severe debility, that patient is going to have exertional dyspnea as well. It's the other converse of it. So as we approach the patient in different ways, the beauty of respiratory muscle training is that offers you a way to, in a holistic way, address several things. And that's not that the only answer to it. It's that I don't want to be telling you that this is the answer to everything, but it's a very simple tool that, when properly utilized, it is a nice adjunct to therapy. That's why it is a nice resource for both the physical therapy, the speech language pathologist, the respiratory therapist, the occupational therapist, and so forth, because it's there in different ways. It just looks.
Yeah, and you said that very well. So while we're all looking at different things, we may be looking at respiratory muscle weakness as it relates to the function that we're typically used to seeing. So another example is, as an occupational therapist, I may be working on activity tolerance so that my patient can get through an ADL session. And so by addressing that respiratory muscle weakness, I can impact that dyspnea, that rate of perceived exertion, so that my patient can do more than just get dressed. They can get dressed and come to the table and have a meal. And we hear that frequently from our patients, that sometimes with all of the benefits that they've received, the one thing that means the most to them, that impact their quality of life, is they're not so exhausted after doing some simple activities. So that in itself, I know, has been very beneficial and improved quality of life, which is really what all of us are about, right? Healthcare clinicians.
Absolutely.
So I did want to ask you about one other thing, because I know our time is getting short. We were all very excited to read in a recent paper published in the American Journal of Medicine by Dr. Richard Severin and others, entitled Respiratory Muscle Performance Screening for Infectious Disease Management Following COVID-19, a Highly Pressurized Situation. In this paper, they laid out a theoretical risk reduction model, which includes 3 items. Number 1 was identifying patients who are at increased risk for impaired respiratory muscle performance. And then number 2, measuring respiratory muscle performance to determine any presence of respiratory muscle weakness, impaired respiratory muscle performance. And then the third phase, or third part of this, was the clinical pathways, was initiating respiratory muscle training protocols in patients with impaired respiratory muscle performance. And I'm going to read what they said about that, is that this model could potentially result in substantial downstream benefits by reducing the number of infectious cases requiring intensive care unit and mechanical ventilation during a pandemic. This would also make intensive care unit and mechanical ventilation resources more available for non-pandemic related care. So I know that this was a paper, an opinion paper, but this is a pretty big step regarding respiratory muscle training. I just wanted to get your thoughts about that.
So it is actually a fascinating proposition, and it's based on a lot of factual data that. So this is not just some weird statement that has no foundation.
Right.
The fact is that we are at possibly quite to gain if you improve the resilience of an individual, if you improve the ability of an individual to withstand a initial injury. And the resilience basically means that the tolerance to the injury is increased. So they will have be less likely to succumb or to deteriorate as quickly. So they will have give a better margin to tolerate the initial injury without this escalating into the severity that then requires ICU management and with a lot more resource utilization and so forth, and potentially even escalating to invasive ventilation, etc. So an obvious example would be somebody who has obvious pulmonary morbidity, let's say somebody who has advanced COPD. We know it doesn't take much for that patient to be tipped over and develop overt respiratory failure. So what we're talking about here is an extrapolation of that concept. So the patients who have identified to be at risk for respiratory muscle performance difficulties, and that it's subject to improvement by instituting respiratory muscle training in a preemptive way. You can actually, in an analogy to the other example I gave you, that patient may potentially withstand the illness better. And not only COVID, but any acute respiratory insult, right? And at this moment, we're dealing with this huge situation that is causing so much upheaval throughout our healthcare. It is even more obvious, but it is not necessarily the COVID patients only, right? So the concept is challenging. I mean, we've never really been so proactive as the article proposes, but it makes perfect sense that we can. We're talking about something very simple. We're talking nothing complicated, risky, expensive.
Not pharmacological?
Nothing. There's no drug interaction. There's nothing here that is. It only requires basically patient engagement.
It sounds like basically what they're talking about is, and I don't want to speak for the authors, but it sounds like you take somebody who's ill or who is at risk, and their respiratory muscle strength may be here. You increase it to here so that if they do become ill, maybe they go from here to here instead of here to here. I know that's very simplistic, but what are your thoughts about that? Does that sound on target?
So yeah, it does. I like your analogy, and let's be honest here that this is complicated, and there you have well known we well documented that we have unfortunately had a number of previously healthy individuals who have succumbed to this illness because it can be so devastating, and there are things about it we don't really understand yet. But there are several things that are the low hanging fruits here. And if we have things that can be done to improve the pre-illness situation of that patient so that their resilience improves, and that is something that is attainable, then it makes sense that we do so. So there are a number of factors, but we are saying that in the setting of somebody who is identified as a risk factor to have pre-existing respiratory muscle weakness, and that can be helped, and that can be improved with a very simple intervention, it makes perfect sense to do that.
Very good. Well, Dr. Aldarondo, thank you so much for your time this afternoon. I really appreciate it greatly. I did want to mention that last year, PN Medical created the Breather University, which is available on the website, following requests from therapists to provide this kind of information and research. So we now have the Breather University, which is housed on pnmedical.com, and it has the videos that people ask for, including how to clean the breather. It has a 3-part respiratory muscle weakness series that takes clinicians from, what is respiratory muscle weakness, to how do you assess it very simply based on your discipline, to how do you document and plan for discharge. So all of that is on there. So I wanted to mention that, that again, that's very easy to access. We are very happy for people to take information and share it. We don't say this is ours, you can't use it, you can't share it. And then if there's anybody who wants to schedule a team training with us, we do that at no charge. We do web-based in-servicing at no charge. So we want to be sure that we're providing clinicians of all disciplines the tools that they need to be able to identify and treat respiratory muscle weakness. And very simply through using the breather, through doing respiratory muscle training. So we want to invite people to reach out to us, call us, email us. We're here. That's really important to us. And again, thank you so much for your time and being here and taking the time to answer the questions that we've been receiving.
Thank you, Christy. It's a pleasure to be with you, and something I believe very firmly in, and it's just a privilege to be part of this. So appreciate it.
Yes, sir. Thank you very much.
Okay. Bye-bye.
Bye.